Behavioral Health Today, a podcast brought to you by the Triad Network. This podcast is designed to share trending topics occurring within the world and our communities and bring them a behavioral and mental health perspective.
Welcome to Behavioral Health Today, a Triad production. I'm your host, Dr. Graham Taylor, and today I'm joined by Dr. Ragan Schriver. Regan is an associate professor of practice at the University of Tennessee College of Social Work, where he teaches clinical and leadership courses. He's also the director of the MSW program, Knoxville campus, and the chair of the Forensic Social Work Certification Program. He's created as well a certification program in trauma-informed care through the University of Tennessee's College of Social Work. In addition to his work in academia, Regan also serves as the special assistant to the president of the Catholic Charities USA to develop integrated health programs within their network. Regan, welcome back to our show.
Thank you, Graham. It's great to be here.
It's really nice to have you back. For those listeners that are just joining us today, Regan was on our show before talking about his program that he developed and he teaches, the trauma-informed care. Really great show, really terrific program, and some really great aspects that he covers around trauma. Very informative, very educational. So I encourage you to go back and take a listen to that. Today, we're going to be talking about trauma again, but we're going to be doing so within the context of our Clinicians Series, where we like to go deeper into the therapist-patient experience. And what we want to do in this series is work to give our listeners an understanding of what occurs within the therapeutic process, kind of behind the proverbial closed doors of therapy. But we want to give you an understanding of what goes on for the therapist. We're going to try and speak very vulnerably and very transparently what we think as therapists at times, what goes on for us and what we experience with the people that we get really the privilege to work with. Regan, as we start out today, what I'd love to hear is in our first show, you had a wonderful analogy of what trauma is. And I'd like to kind of just start the show today with giving us a cornerstone understanding of the definition around trauma. Can you give us that?
Yeah, for sure. I just am excited to be able to talk with you all, and also just to kind of say that I'm standing on the shoulders of giants. At the University of Tennessee, we have some great folks that have put so much implanted some knowledge into me and an understanding of stuff on the area of trauma. And so I'm excited. I just want to kind of give a little shout out to those folks because
that's awesome.
Maybe they'll listen.
That's good.
But when I think about trauma, I know there's so many discussions and concepts of what is trauma, and there's definitions that I know like the APA has put out and the NASW sort of talks about what these trauma is. And I think sometimes I feel like that there's this focus on the external experience, that the external experience is the trauma. So then therefore we categorize things as a flood or abuse or something that external thing is the trauma. But really what we're coming to understand is it's more of the person's internal experience. Mm-hmm. So I kind of came up with this analogy that we as human beings have this system that's built inside of us that could be analogous to, like, I live in Knoxville, Tennessee, and we have a great sewer water removal system. It's probably not the thing that you would lead with, but when it rains here, the water system takes the water off the roads, and there's the sewer system that just removes the water. So when a normal, typical rainfall comes, the sewer system that we have in place removes the water and everything can be okay. Analogous to the system, the nervous system that we have as human beings, that when daily stress comes about, we can handle it. There's this typical stress response that we have that we can respond to, and it resolved. There's maybe the stressful, we have to take a test, or our boss asks us to do something very stressful, but we deal with it and we respond to it, and then it resolves in our body and we're okay. But then sometimes here in Knoxville, there might be a big, huge flood, a big rain. And so then the water system becomes overwhelmed. And then the water gets backed up, and then there's damage on the roads. There's some of the earth kind of shifts around. Maybe a home might get shifted off of its foundation. All these things that happen because of this flood. And then the system becomes overwhelmed. But then over time, still there's sort of an impact that's been left on the roads or on the ground or on that home that's been shifted off. There's still that impact that's there. And I think that's sort of, again, analogous to our nervous system, that sometimes big things happen to us and overwhelms our nervous system and our ability to be able to cope or to deal with it, and it leaves a lasting imprint on us.
Amen.
So then we end up with this imprint on us of these traumatic events or traumatic things that are sort of the flood that's overwhelmed our nervous system, which is the stress response system.
Yeah, I think that's a terrific visual and a great picture of what happens. I like what you're saying. It is an internal experience. You don't see it on the outside per se. And we know that it does, cause kind of a unique wiring and kind of sets off certain things in our mind. We know from MRIs that you can kind of see those traumas get lit up when someone's in that state and activated. And you're talking about how that flooding occurs and it shifts things and it doesn't get processed. I like to think sometimes that trauma is an experience outside the realm of normal experience, where we don't have the ability to understand, process it, deal with it, cognitively, the way you're saying, and it actually does leave some things really kind of in a different state, doesn't it?
It really does. When that flood comes, I have to adapt to where the road is broken. And so then I have to find a new route to go around. And I adapt because during this traumatic experience of the flood, I've adapted my life to that. Yeah. So if I think about if there's been some sort of maybe sexual assault or physical abuse or whatever sort of traumatic experience that my body experiences as negative, I'm going to adapt to it. I'm going to adapt my life or my patterns of behavior or my pattern of thinking around that. And sometimes those adaptations in any other setting would not be adaptive. Yeah. So then I'm living my life in this way that may be still oriented around this traumatic experience, but I'm still behaving this way, if that makes sense.
It makes total sense. What I really like about that too is that those things that once helped us survive and manage the abnormal environment we're in, these are really good adaptations to that. However, those adaptations become problematic later on, don't they, in our lives, whether it's about trust or interpersonal relationships. We're going to talk later in our show today, and I'm really excited about this part of how we use a therapeutic relationship to work through some of those maladaptive, let's put it this way, those adaptive abilities that now are maladaptive interpersonally in their adult life when they're no longer necessary, but this is the only roads that they know how to go down.
For a few years, I worked at an eating disorder unit that treated persons that had anorexia and bulimia specifically. And I feel like that the adaptation of the diet to either extreme starvation or binging and purging became that adaptive way to try to handle this stress or the trauma or the experiences of their life. But then it almost became intimate to them, that this adaptive at the time behavior became so intimate to them that almost kind of like it was a friend. I know that sounds extreme, but this close friend that they had that it was very difficult to let go of. So sometimes those adaptive behaviors that have become maladaptive are so tough to change because our body just gets used to it and wants that, whatever that is.
And as you're describing this too, we get to be reminded that these are formed unconsciously. We don't know we're doing this. This is being done without our awareness. And now you're telling me the only way I've known to live my life safely, you're telling me is no longer the right way to be living my life. Mm-hmm. And my first thought is, are you crazy? I'm not going to let go of this friend. I'm not going to let go of this way of staying safe. And I know no other way. I have no other model. The way that I see my, the world in this way. Let's hold that. We're going to come back to that a little bit. I want to maybe shift into this, while we need to be in this work, well trained, the schooling, the supervision, the licensing process, the competencies that we are required and need to have in order to be effective in this work. I really believe that we are our own greatest tool, though, as therapists in the therapeutic process, where we get to use ourself consciously, intentionally, in that therapeutic relationship. How do you encourage your students to think about becoming aware of themselves, their own upbringings, maybe their own personal traumas, such that they're able to do that work so that it doesn't interfere with the things that they're going to be sitting in front of and hearing, so that they can kind of be in that place themselves, to be that vessel, to hold these things? How do you encourage that?
It's something that I feel like I constantly kind of talking about with my students. And I feel like I have to be honest and say that I sort of draw on my own experience. I think as a teacher to students, it's a little bit of a different boundary that maybe I might share a couple things about my own experience, not too much, but just enough so that maybe that they could connect that to themselves. I know for myself that I feel like that for part of my career, maybe I was afraid to look at things in my own life, in my own development. And so it became sort of, I'm holding my hands up in front of my eyes, like, because I became blind sometimes to something that was going on in a client because I flat out didn't want to address it in myself. Right. And so I was doing a disservice to the client because I was doing this, maybe a thing that had been adaptive to me even at one point of not looking at this issue, whatever it was. And so then therefore, I think it impacted the therapeutic relationship. And so, hey, students or anybody that's listening, this thing that we're doing, we're not going into to a thing where we're making widgets. The use of self is the essential part of this process. So I remember being a little bit frustrated thinking, why am I not making progress in some of these situations? And I had to look hard at myself. And I have to say it wasn't easy. And I'm still trying to figure it out, as we all are, kind of thing too,
I really like that. You say that in those moments when, if I haven't done my own work, one of two things can happen, maybe almost two sides of the same coin. One, and if I'm with somebody that needs to talk about something that I haven't worked through, but they need for their therapeutic process to continue, I may not want to go there. And unconsciously, I'm directing us in other directions. Or if I haven't done my own work, I'm going to do it vicariously through them in a way where they may not be ready to go down that path, but I might be beginning to push in ways that is premature for their readiness to take a look at it.
Wow, that's I love how you coined it, as said, two sides of the same coin. I think that's a terrific point to make.
Yeah. So what you're saying, without our own work, which I would encourage all students, and I think even as therapists, our ongoing work, if we're going to be our best tool, let's make sure that, we're doing that work so we can be kind of present in that way. Just to our listeners, Regan and I had an opportunity to talk earlier this week, and we were talking about, ideally in our show, he and I get to model what we hope all of our colleagues get to do with somebody in their life. And that's work to a place where they can speak honestly and candidly. They can be transparent with one another. It's hard sometimes to say, hey, man, I had this thought in therapy. Can you believe I had that thought? Or this came up for me and I got triggered in this way. And if we can find a place and a person or persons to be able to open up this way, this is where we become our best tool. And part of what I was talking with Regan about and what he was encouraging us to do in this show was to kind of model some of that, where we're talking about things in a very honest and candid manner. And so I guess my next question, and I'm going to jump in on this and try and be as transparent as I'm asking you to be, Regan, but around what are some of the tougher cases that you find being most challenging for you? Some of the presenting problems that are hardest to deal with?
I think I have a couple of thoughts about this. Two cases immediately come to mind. One is kind of humorous. The other is a little bit more painful. The one that was sort of humorous. So I was brand new. This was years ago. I was brand new working in an alternative sentencing program with folks that had some sort of influence with the justice system. So it was a men's group, and there were 10 guys that I was leading this therapeutic men's group. And I took to heart the thing about boundaries. You keep your boundary up. And so the group was a disaster. I wasn't being very real. It just wasn't I wasn't in relationship with them. I was sort of like providing some sort of service. Like I was just doing what I read in the book rather than really utilizing myself. Well, one day I went out to the car to get something, and all the guys were out on the front porch having a smoke before the group. And they said, hey, Regan, come on over. And I thought, oh no, I can't talk to them. This is a boundary. It's outside the session. What am I going to do? And so I went over and I said, okay, well, and I went and talked to them. Well, I didn't reveal my deepest, darkest secret, but I sort of talked to them as a real human being would. And then I have to say, in that moment was a big breakthrough for me. We went in, we had a group. That group became more successful because I think that I just thought, okay, you're trying to be something that you're not, Regan, and just be you. Not that I'm pouring out all my issues, but I'm just trying to be real.
Yeah, it's a real relationship, isn't it?
It truly is, and that's what I feel like is so hard. I think sometimes for us is to discover that and to remember that, and that I'm using myself in this engagement to model the way that a healthy relationship could be. I'm not the friend. I'm a human being in in a real relationship.
It's a unique and one of a kind relationship, but it is nonetheless a real relationship. We'll be right back after word from our sponsor.
Continuing education is both a requirement and a learning opportunity, but finding the right CE provider can be challenging. AATBS, a triad company, offers continuing education for psychologists, social workers, marriage and family therapists, counselors, and behavior analysts. CE courses are available both individually and as part of our new All Access Pass. All Access Pass provides a library of over 250 unique courses. That's more than 800 hours of CEs, with new courses being added every month. As a special offer, Behavioral Health Today listeners can save 15% on CE purchases. Visit us at aatbs.com/BHT and enter promo code BHT15 during checkout. That's aatbs.com/BHT. Check out our library and check off your CE requirements today.
What was the second case?
So this was a case where this was someone I was seeing when I was at Catholic Charities, and the person probably had a personality disorder. It was very hard. The boundaries, again, were very hard. The person found my phone number at home and tried calling me and would find out where I lived, things like that. But I had learned in school, and actually I learned this from another colleague too, that I was very conscious of wanting to make sure that I gave enough time to the client, but also wasn't like overextending the time so that the next person and those other things I had to go do. So I kept up kind of in the corner of the room so that I could like be attuned to the person, but glance over and see what time it was and not go like put my wrist up to see, well, now it's what time is it? So the person saw the clock and perceived that as a rejection of him. And I was just flabbergasted by that, and just then wanted to make everything, okay for him. And like, I don't know if I actually handled it right. It became really kind of a painful thing for me because I got so stuck on myself and what if I had done wrong, rather than taking it as a therapeutic moment to talk about what does rejection mean to you and how does this perceive as rejection. And I wish I could go back.
No, I like that. So you're talking here about how a patient's reaction in a moment is really revealing something deeper for them that predates you, that happened in their life, that gets interpreted in a moment, in this case as rejection. Maybe I'm not important, or, is this really real because we're on a clock? And I think what you're raising right there is we can drop into our own, hey, what have I done? Or maybe even our own shame place of, man, I didn't handle this very well. But those are tough moments, aren't they?
Oh, yes. Yes. And I think that whole thing about realizing I don't think that was an error or a mistake to place a clock somewhere so I could be, monitor the time. I don't think that, but to talk about, like, I think to use the moment as how is this impacting me in a way to get in touch with that a little bit so that I could maybe better reflect that back to the person.
Well, what you're talking about here is countertransference, where their reaction, back in the day, countertransference was something that was seen as problematic and something that needed to be kind of worked out in your own therapy as a therapist. Versus now we understand that, in kind of the countertransference pie, if you will, there's our own stuff, there's the complementary countertransference, there's indirect countertransference, there's concordant countertransference. And what you're talking about here is a complementary countertransference, isn't it? Where you're being pulled into an enactment, something where the patient once upon a time had some kind of abandonment or some kind of, something conveyed to them about, well, I'm not important to you because you're looking at a clock and we're just on the hour, and who am I to you? And all of these things. And all you're doing right there is making sure that you keep a good therapy hour and you keep a good boundary. But within that boundary, these things emerge. And so, but what we can also do is we don't recognize that sometimes in ourselves. And we all get to this place, particularly as young therapists, where we feel like, oh, my stuff gets kicked up and am I not doing this right? And we kind of drop into that versus what you said. What I like is, hey, what does that mean to you when I look at the clock? And tell me what you find getting kicked up for you. So we get to use the in the moment kind of therapy relationship, don't we, to find out, hey, what does this mean for you earlier in your life or maybe even currently?
I love the way you phrased that. I have to say, I feel sort of in my life, I sort of bounced back in quotes from that experience because I had an awesome supervisor. And I think sometimes I know in our profession, we look at supervision like as the graduation day when it's done, that like I've accomplished, I can get my license now because of my supervision hours are over or whatever. But I feel like that having a supervisor is a unique relationship. It's like somebody that I can be real with as well. But then that supervisor for me isn't a friend or really a colleague, but somebody that is almost in a therapeutic sort of role for me. It's been so helpful. It was so helpful.
That's really good. I want to stay with that piece in just a moment as we talk about some of the internal experiences that we can have as therapists. But I want to go back over something about this idea where this relationship is a real relationship. Truly, we have the privilege to have with those that entrust us with their lives. But we know that those that experience a trauma have the most basic trust in their lives typically betrayed somehow. Let's stay with that one, just maybe relational traumas. And their security operation, what you were talking about earlier, really clearly causes them to maybe be cautious or leery or slow to trust which can impact their ability to bring their trauma up into the conversation or up to a conversational level in the therapy with you, which is necessary for the therapy work to get done. I need you to kind of share and bring things with you. But if trust is a basic issue that's been, breached or betrayed, it's so very hard. When you're working with someone, how do you name and normalize these security operations on the one hand, and at the same time explore how they might begin to take some risk with you or kind of lean into this relationship so they can tell you the story and you can join them in it?
This is going to sound like the old trite, kind of from my perspective, of the unconditional positive regard, which our Carl Rogers would describe and just say, I just feel that whatever I can do, my facial expression, my bodily presence to the person could just be of acceptance. And that I'm here. I feel like that it's a challenge to think about, like, if I've been brought up and I know that I want to value the human dignity of every single person that comes to me, no matter what the experience is, but maybe I've been hurt or things or been influenced by things or have my own bias towards people or a person or the way a person behaves or the way a person is, I've got to try to work through that. Or how can I just have that open acceptance and the recognition of the dignity of the person that's before me and the challenge that they're embracing to come be with me in this moment,
Well, I like that. I mean, I could even see, saying something like that of, you're coming here and you're entrusting me with some things. And I'm going to trust that's going to be challenging and also, hopeful for us both. And I'm going to try and show up as best I can, but I so want to acknowledge what you're doing by being here. I really like that. And kind of that, Carl Watch talked about WEG, warmth, empathy, and genuineness. You're hitting it right in the head.
Also, I feel like many people that come with relational struggles or maybe traumatic experiences have been told, trust me, it's going to be okay. You can put your trust in me. And it's been nothing but violated. So it's almost like the word trust becomes a triggering reactive experience. So how do I convey to somebody, I want you to trust me and I want you to find trust here. But I feel like maybe like it's putting it back in their court to say, look, I recognize your dignity and I recognize your value and what you can do. It's up to you to trust. How can I be a trustworthy figure for you? Like kind of putting the ball in the court of the person we're working with.
What I love that you're doing right now is what you're saying is, what if we just name these things? What if we just normalize and kind of say, hey, I would imagine from the stories you've told me, all these relationships have been, betraying and trust breaking. And here I am asking you to trust me. Holy cow. And you're saying, bring it up, ask what it's like, and maybe how can we build trust together, if I'm hearing you right?
Yes. That's, I think, exactly right. Something else that is sort of tangentially related, but this is going to be geeky for just a second. But like, I've been reading about this concept of mirror neurons, which are these neurons in your mind, and that how they can reflect what's going on in another person. So I was thinking about this, and I read something about it. So say if I'm in a therapeutic situation with someone, and they're telling me something terrible that happened to them. And if my facial expression to the person is one of like shock, horror at what they're telling me, I think in my mind, I might be thinking I'm really conveying that I'm with them and that this was really horrible. But then what the person might be seeing in my shock, horror face is, oh no, he doesn't like it either. This is terrible. So I have to be empathic and listening and be aware that I'm not just like conveying some sort of horror to the person as well, and that I'm as freaked out as they are. They're going to need somebody that's a steady presence in it.
Yeah, it makes total sense. You're talking here about kind of that part of the countertransference where I understand what they've gone through, but I want to come in kind of a concordant way where I want to come in with empathy. I want to hold the trauma. I want to hold the reaction that they're having with them at their level. But you're also talking about that mirroring process being an essential part of what kind of psychodynamic therapists refer to as corrective emotional experiences. So they've had people betray their trust, and you're saying, I want to be able to be a corrective emotional experience with you. And that can change our wiring here. That can change the patterns and pathways of how, when we have corrective emotional experiences, someone begins to build the very trust that someone took away from them back with you in those therapeutic moments.
Wow, that was really well said. That's great. Thank you.
Well, no, what you're saying though, but it hinges upon that mirroring, doesn't it?
It does.
Both mirroring in our looks, mirroring in our words, holding what they're saying.
Mm-hmm. I know of one colleague that uses the phrase a lot. I want to create a space for this situation, this person. I love that. I kind of like that. I want to create a space for whatever you want to bring, for who you are.
What a great invitation. Yeah, what a great invitation. You have a very nice way, man. You're genuine, you're lighthearted, but you've got this great depth to you, and it's inviting of people just to feel safe. So I really like that. Folks, please pardon the interruption, but we will continue this discussion on our next show. I want to thank our guest, Ragan Schriver, for coming on the show today. For more information about the University of Tennessee's College of Social Work and their postgraduate trauma care certificate program, please visit www.csw.utk.edu. And lastly, I want to thank our listeners for tuning in today, and we'll look forward to seeing you next time on Behavioral Health Today.
We appreciate all the support from our community, and if you like our show, one of the best ways you can support it is by giving us a 5-star rating and leaving a review. Behavioral Health Today is a podcast part of the Tribe Network, all rights reserved.